The Practice of Cardiac Sonography 1, Lecture 2 is an introduction to echocardiographic image acquisition. The contents of the lecture are 1. Aspects of professional practice, 2. Imaging conventions, 3. Apical images, and 4. Subcostal and suprasternal images. Learning outcomes. Following this lecture, you will be able to employ relevant sonographer and patient position techniques. 2. You'll be able to apply correct transducer positioning and alignment for acquiring apical images. And thirdly, apply correct transducer positioning and alignment for subcostal and suprasternal images. I recommend that you refer to and read Chapter 2 of Essential Echocardiography to support what is described in this lecture. Firstly, a review of some of the essential aspects of professional practice. As mentioned in the Practice of Cardiac Sonography Lecture 1, it's important to adopt a well-balanced, stable and comfortable imaging position for every patient. Ideally, a cardiac sonographer should be positioned on the left-hand side of the patient and be seated wherever possible. Shoulder stability is important. The shoulders should be kept as close as possible to a neutral position. That is to say, they should be even in height. They should not be rolled forward or in an abducted position for too long. When holding the transducer or the imaging probe, aim to support its weight evenly. Change grip slightly at regular intervals and avoid trying to hold the transducer too firmly. Good imaging practice includes constantly considering your posture while imaging and taking regular breaks, as well as maintaining good general fitness and strength. Things to avoid include unnecessary bending or prolonged twisting and prolonged reaching. Aim to adopt the kind of position that the sonographer on the left of this slide uses, rather than the one that the sonographer on the right-hand side is using. As modern ultrasound machines have been designed with sonographer ergonomics in mind, learning to utilize the adjustable monitor, keyboard and platform will help. Adjusting the chair you sit on, as well as the patient couch, are also helpful. Two, imaging conventions. There are 4 standard echocardiographic imaging windows. They are the left parasternal, the apical, subcostal, and suprasternal windows. For parasternal and apical images, patients should be positioned in the left lateral decubitus position. By convention, standard echocardiographic examinations start with images from the parasternal position. These images are acquired by placing the transducer in the 3rd, 4th or 5th left intercostal space. Subcostal and suprasternal images are acquired with the patient supine. Subcostal images are acquired by placing the transducer in the midline or slightly to the patient's right, just below the ribs, whereas suprasternal images are acquired by placing the transducer in the supraclavicular fossa and aided by asking the patient to tilt their head backwards and to the left and we'll go into that in more detail later in this lecture. Electrocardiogram, that is ECG monitoring, should occur with every examination. Knowing the heart rhythm and heart rate are important for measuring and evaluating images. Image acquisition should include as many cardiac cycles as needed for accurate assessment. This may be 1 or 2 beats only for normal images, but 2 or more for abnormal images, and extended captures for patients with an arrhythmia. Like all other organs, the size of the heart is related to a person's overall size. Therefore, it's important to enter the patient's height and weight into the ultrasound machine at the start of the exam. This ensures that measurements such as volumes and mass calculations are indexed according to the patient's size. Blood pressure, particularly high blood pressure, can affect certain measurements. Entering the patient's blood pressure also allows for more accurate and evaluation of certain measurements. Apical imaging. The apical position is an essential imaging window. From this position, multiple views of the heart can be acquired. With the patient in the left lateral decubitus position, apical images are acquired with the transducer near the apex of the heart, that is, in about the 5th intercostal space in the mid-axillary line. There are 2 standard apical views, the apical 4-chamber and the apical long-axis view. The apical 5-chamber view is a modification of the 4-chamber. The apical 2-chamber is a modification of the apical long-axis view, and we'll consider these shortly. Firstly, the apical 4-chamber view. This view provides a view of all 4 heart chambers. It is achieved by positioning the transducer in the 5th intercostal space in the mid-axillary line with the imaging marker pointed leftward at about 3 o'clock. Care should be taken not to foreshorten apical 4-chamber images. That is, the aim is to acquire an image that displays the heart in its greatest length. By convention, the ventricles appear at the top of the sector and the atria at the bottom. So, inferior structures are shown at the top and superior structures at the bottom. Left-sided structures are displayed on the right, and right-sided structures displayed on the left. A well-oriented apical 4-chamber view will display the cardiac crux or cross near the midline of the sector. This structure is formed vertically by the primum interatrial septum and the membranous interventricular septum, and horizontally by the septal leaflet of the tricuspid valve and the anterior leaflet of the mitral valve. The ventricular and atrial chambers should be free of echoes, that is, black. Normally, the left ventricle is the largest chamber with the greatest muscle mass, and the left ventricle forms the majority of the apex of the heart. The atria will be similar in size, with the left atrium modestly larger than the right, and the the interatrial septum should also be seen. Trabeculations in the right ventricle will appear more prominent than those in the left. The moderator band is a distinguishing normal feature of the right ventricle. It traverses the RV near its apex and contains conducting tissue. Normally, the insertion of the septal tricuspid valve leaflet is more apical than the insertion point of the anterior mitral valve leaflet. A well-oriented apical four-chamber image should appear similar to this image. Numerous qualitative 2D assessments and quantitative 2D measurements of the left ventricle and left atrium can be made from the apical four-chamber view. Reducing the depth displayed and using the zoom function increases the accuracy with which such measurements can be made. The apical four-chamber view is an important view for obtaining Doppler information about the LV. Pulsed wave Doppler measurements of left ventricular inflow provide valuable information about left ventricular diastolic function. Tissue Doppler imaging provides valuable information about left ventricular systolic and diastolic function. The apical five-chamber view is a variation of the apical four-chamber view. By tilting the transducer superiorly slightly and with minor angulation towards the patient's left shoulder, the left ventricular outflow tract, aortic valve and aortic root come into view. The left ventricular outflow tract is considered to be the fifth chamber. From the apical five-chamber view, important information about blood flow in the left ventricular outflow tract and across the aortic valve can be acquired using pulsed wave and continuous wave Doppler. The apical long axis view. This view is obtained by rotating the transducer anti-clockwise from the apical four-chamber view and tilting the face of the transducer superiorly. Anti-clockwise rotation should happen until the image marker is pointed at about 11 o'clock. Like other apical images, inferior structures are displayed at the top and superior structures at the bottom. In this view, anterior structures are on the right and inferior structures on the left. And similar to other views, by reducing the depth and using other modes, valuable information and measurements are made. The apical two-chamber view. This view is a variation of the apical long axis view, with the transducer positioned again in about the fifth intercostal space in the mid-axillary line. The image marker should be pointed at about 1 o'clock. At times, the apical two-chamber view may be challenging because the footprint of the probe may not fit easily into a rib space. Asking a patient to inhale or exhale may help to improve image quality. And again, care should be taken to try not to foreshorten the image. In the apical two-chamber view, anterior structures are displayed on the right and inferior structures are displayed on the left of the screen. As such, this view is often used to assess the motion of the left ventricle's anterior and inferior walls, which are usually supplied by different coronary arteries. The apical two-chamber view is another view from which important 2D and Doppler information can be obtained. By reducing depth, and again by using the zoom function, measurements such as left ventricular and left atrial volumes can be measured and obtained from this view. Subcostal imaging. As the name suggests, subcostal images are acquired from below the ribs. For optimal subcostal images, the patient should lie supine, with their knees bent if possible. Subcostal images are acquired from below the xiphoid process, which is at the inferior margin of the sternum, often with the probe just to the right of midline. With the transducer below the xiphoid process and just to the right of midline, and with the probe's image marker at about 3 o'clock, a subcostal 4-chamber view can be acquired. In this view, anterior structures are displayed at the top and posterior structures at the bottom. Superior structures are shown on the left and inferior structures are shown on the right of the sector. The subcostal 4-chamber view is often a particularly good one for imaging the interatrial septum, as the septum is nearly perpendicular to the ultrasound beam. By applying zoom and color Doppler, this view is commonly used to check for defects in the interatrial septum. A subcostal short-axis view is achieved by rotating the transducer anti-clockwise from the 4-chamber view until the image marker points leftward at about 1 o'clock. From this view, by angling the transducer slightly rightwards, the inferior vena cava can be imaged. Suprasternal imaging. The suprasternal position is most often used for imaging the thoracic aorta. With the patient lying supine and with their head tilted back, the transducer is positioned just above the suprasternal notch. With the transducer in place and the image marker pointed leftward at about 1 o'clock, a long-axis view of the aortic arch can be acquired. In this view, superior structures are displayed at the top and inferior at the bottom, anterior on the left and posterior on the right. Color, pulse wave and continuous wave Doppler imaging can be used and provide important information about blood flow in the thoracic aorta from the suprasternal window. In conclusion, to start this lecture we reviewed some of the essential aspects of professional practice, including sonographer positioning, which is important for short and long-term sonographer health. We reviewed correct patient positioning, which helps to ensure the best images are acquired each time, and the need to use ECG and indexed measurements for each patient. Apical imaging was part 2 of the lecture. Patient positioning, transducer positioning and orientation and image orientation for the different apical views was discussed, together with ways to adjust apical imaging for different measurements and imaging applications. Subcostal imaging was discussed next. Patient positioning, transducer positioning and orientation for 4-chamber and short-axis views. And lastly, we briefly discussed patient and transducer positioning for suprasternal imaging of the aortic arch.